Good afternoon and good morning to you if you're on the West Coast. My name is Jose Leon, Chief Medical Officer at the National Center for Health in Public Housing. I want to welcome and thank you all for attending today's webinar, Understanding the Social, Physiological, and Health Effects of Excessive Heat on Special Populations. This webinar is being recorded, and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, we will have a question and answer session. I would like to remind the audience to please complete the post survey that helps the National Center to improve our webinars and our activities. And I would like to say thank you to HRSA for allowing us to make this webinar possible through a publication grant. The Public Housing Primary Care Program has 106 health centers that are located in or immediately accessible to public housing. In total, there are 297 health centers that are in or immediately accessible to public housing, but only 106 receive PHPC funding to provide services to public housing residents. Before we get started, I believe that it's very important to review some of the demographic facts of people living in public housing. Across the nation, there are over 2 million residents living in public housing and another 4.7 million residents living in Section 8 housing. The average household size for residents of public housing is 2.1 people and 2.4 for residents of Section 8 housing. Nearly 300,000 or around 16% of residents in public housing are seniors, and approximately 500,000 or 10% of residents of Section 8 housing are seniors. 36% of public housing and 43% of Section 8 housing households include a member who is disabled. In regards to income, Social Security payments are the primary source of income for approximately 55% of seniors in public housing and 57% of seniors living in Section 8. The residents of public housing face several barriers to health. For example, safety concerns cause residents to spend more time indoors, reducing activity levels and amplifying obesity and related issues. Additionally, where public housing is typically located in isolated areas, poor access to healthcare, social services, and high quality of fresh foods are contributors to substandard health. This is 2015 data, and in 2015, the 297 health centers provided services to over 1.5 million patients. The 106 PHPC sites provided services to almost 500,000 patients. Out of these patients, almost 31% were less than 18 years old. Around 62% are adults between the ages of 18 to 64. 6.8% of the patients were older adults. Almost 22% were uninsured, and around 58% are on Medicaid, and 7.7% received Medicare. 62.3% of patients were reported with a poverty of 100% and below. I'm going to skip some of these slides because I would like to focus on this one, and this is one of the reasons why we believe this is an important topic for those providing services to public housing patients. And as you can see, the number of patients seen in community health centers located in or immediately accessible to public housing with a diagnosis or that have been exposed to heat or cold has increased dramatically over the years. In 2015, there were approximately over 140 visits and around 80 patients who were seen with either any of these conditions, or either they were exposed to heat or cold. So we believe this is a webinar and a training assistance that we can provide just to improve and create awareness for those providing services to public housing residents. Now, I would like to introduce our first speaker, Julie. Julie Tranton is the director of the Oceans and Human Health Initiative at the National Oceanic and Atmospheric Agency. Julie is responsible for developing and coordinating NOAA's health portfolio with other federal, state, local and international agencies, academic and private sector partners. She has worked at the intersection of climate, oceans, and health since 1997, designing and directing multidisciplinary and multi-partner programs, the Oceans and Human Health Initiative, and the Climate Variability and Human Health Program. Julie also co-chairs the U.S. Global Change Research Program, Climate Change and Human Health Group, represents NOAA on the International Working Group of the U.S. Group on Earth Observations, the Integrated Information System for Health Lead for the Group on Earth Observations, and is directly involved with the World Health Organization and other partners in the development of the Integrated Information System for heat, cholera, and other water-related illnesses. So without further ado, I will turn it over to Julie. Good afternoon, Julie.
Thank you, Jose. Thank you for the very kind introduction, and thank you very much for hosting this webinar and asking me to be a part of it. I'm really thrilled to be here. So my job in this webinar is to set the stage a little bit for where we're headed in terms of extreme heat. So I'm going to do a little bit about a few slides on how we know the extreme heat events are going to increase and then what we're doing about them. As Jose said, I work for the National Oceanic and Atmospheric Administration. I'm actually in the climate program, but my job, as Jose said, is to coordinate the health activities across our agency. And most actively right now, I am working on this national integrated heat health information system, along with our Centers for Disease Control and several other agencies, as you'll see throughout this talk. And just to put the bottom line up front here, my objective is to both increase awareness about this issue for you, but largely at the end to be able to engage in some conversation about how you see yourselves using this information and what you need, and how we can partner with you in the long run to make sure that you have what you need to better prepare yourselves and your populations for the extreme heat events that are coming. So starting with the end first, that's the goal here. All right, so this is not a climate change 101 talk, but I wanted to start with a slide that talks about why we know the world is warming, and these are 10 parameters that we monitor in the long run that over decades have shown increases in sea surface temperature, decreases in Arctic ice, ocean content, and things that affect, all of these things affect the way heat is distributed and the frequency of extreme heat throughout the United States and actually globally. The other piece I want to do is a little bit of a framing conversation, and that climate is a continuum, and it starts with weather. Climate is basically just an accumulation of weather over time. So weather is the shorter time scale, minutes, hours, days, up to 2 weeks. Subseasonal, seasonal climate information, things like El Nino and La Nina, that we can predict. They have impacts on our climate, as you probably know if you live out west. The El Nino and La Nina affect the drought and heat situation directly on the western seaboard. They affect things throughout the rest of the world, but they're moderated by other factors as well. And then it's changes that happen on, decades to centuries as well. So there is a time scale of climate impact, but there's also a time scale of decisions. And so when you think about heat, most of you are probably thinking about a heat wave tomorrow is coming, what am I going to do? But my objective here is to say that there are a lot of things that we know are coming, and we know with a longer lead time than maybe we're communicating very well to you. So there are things that you might be thinking about to do ahead of time that would help mitigate the impact of a heat wave or an extremely early heat season or more heat waves during the season. things that you would know that I wouldn't, because I don't do your job, you do. But what would you be doing if you knew 3 months ahead of time or 6 months ahead of time that it was going to be a hotter than normal heat season, or the heat season was going to start earlier? So part of this is, how do we actually communicate about these time scale issues and information needs that you might have for budgeting, decision making? Who's, how many cooling centers do you need? When do they need to be open? How do you build your bus stops? How do you build your cities? Those kinds of decisions. But I know that most of you are involved directly with the people who are most directly affected and some of the most vulnerable populations. So it's a bit of a double-edged sword in terms of, how do we communicate the right information to the right time scale to you, so that you can actually both protect your populations and help them plan and help your communities plan. So we're already seeing some of these changes of climate over time. We know that heat waves are going to increase in length and frequency and intensity over most of the land areas. The same is also true for flooding and cyclones and hurricanes, but we're not going to focus on those here. We could have a similar conversation about those that we're having with heat. So this slide just is a way of saying we actually do forecasts across time scales, and it isn't just necessarily an emergency response mode in which we need to find ourselves on a regular basis. We could do a better job of planning and preparing ourselves for what we know is coming. So it isn't just an emergency response mode. All right, this is my one slide that talks about the impacts of climate more broadly, and the rest of it's going to be focused just on heat. So, we have extreme weather events, which we're talking about. The blue is rising sea levels. The orange in the middle is increasing carbon dioxide. And the red is rising temperatures, which is what we're talking about here. The impacts on the second circle are the sort of biological impacts. And then the outside area is the area where you would, I expect, to be most concerned. And I put this up because the title of this session is about vulnerable populations. And we're talking about heat, but there are other things that are affected by climate change, which you might be dealing with. And also heat it affects the urban populations in a particular way, both children and the elderly most vulnerable, but the outdoor workers, the people who are actually, the middle age, the 18 to 64, I believe on Jose's slide, are highly at risk too, depending on what they do for a living. So I put this out to say that there are things that we should be thinking about beyond heat as you're dealing with the populations you care for. You might be seeing things that you wouldn't normally have seen. Lyme disease, we know, is spreading. Some of these waterborne diseases are spreading. So it's just a way to make you aware that there are changes coming, and just to be on the lookout. We can talk more about maybe how to deal with some of those down the road. All right, so this slide just basically says, here's how we know that temperatures are on the rise. But if you look at the color gradient, where it is darker red means that the temperature change is in degrees Fahrenheit, so that's the number of degrees above normal that we expect to see in these areas. And you'll see that it isn't just in the tropics that are getting warmer. In fact, it's in the northern latitudes and some of the southern latitudes that we expect to see the more rapid increases in emissions and in heat. And this is just based on the current emission scenario. So this is if we don't do anything. We know that heat waves are going to be more frequent and more intense in the future. So what we're used to seeing as an abnormally hot day is going to be normal for us in the future. So what does that mean? Well, we've set up our conversation here about some vulnerable populations, and I just wanted to kind of lay them out a little bit. Obviously, the elderly and children, and I raise children in part because I have the opportunity to visit some of your healthcare facilities in Chicago and a couple of other places through Jose and his group. And it is the elderly, but it's also children. I mean, I saw lots of children coming through, and they practice their outdoor events, their athletic events, their just, recess times at the peak heat times of the day. So if those times of the day are going to get hotter and more frequent, we really have to figure out how to protect our children, whether it's changing when they're outside or making sure that their parents know how to detect the effects of heat stress. But those are often overlooked because you think you want your kids to be outside, to be active, you don't want them in front of a computer or on playing games. But in fact, how do you actually encourage both the healthy activity of being outside, but the protective mechanism of making sure they don't have heat stroke? So I'll skip over this, except to mention that the agricultural context is a lot about the outdoor workers, construction workers who are pretty high risk. Okay, so what are we doing about this? This National Integrated Heat Health Information System I'm going to finish up talking about was designed to pretty much pull together the federal assets and coordinate those so that we could begin to help communities plan for extreme heat over multiple timescales. I'm not saying we have the emergency response time down. We'll hear from two other speakers about that. I'm not sure that it's perfect, but I think that system is better understood. But how you manage 2 weeks, 3 weeks, a month, a year ahead of time, maybe not so much. So this National Integrated Heat Health Information System was launched by the White House in July of 2015, has several agencies, which I'll outline in a minute, involved. But we also have a piece that's looking at pilots around the country and around the world, actually, because so many cities and counties have heat action plans or are working to manage heat. We're not starting from scratch. It was really more, how do we actually learn from those of you who are working on heat already, what's working and what's not, what should we be predicting, what kind of communication materials should we have. On the federal level alone, we wanted to make sure we were sending consistent information. So all of the information about heat management, extreme heat, and the guidebooks are now all in one place on this portal. I'll show you. At the bottom right of this slide here is actually a snapshot of an earlier version of the NIHIS website. The pilots I mentioned are designed particularly to help us drill down with those of you who are working more actively on heat wave to understand what you need and to get at those time scale questions, because the decisions are made obviously at a very local and community level. So, doing a national level effort really isn't going to work so much. We just have to figure out what we can do at the national scale to predict and provide information that actually lets you all do what you need to do at a more local level. All right, so two slides just on what NIHIS actually is, and I highlighted the part about reducing heat-related health risks to people and communities and economies by enhanced planning from days to weeks to months and years. So I want to stress that multiple time scale of communicating information. The second piece is the consolidation and coordination function, which I mentioned, which allows us to provide, theoretically, information that is more useful to you, but we don't know what that is unless we work with you to hear from you what you actually need. And then the last piece is just the components of NIHIS, which is both the federal group, the pilots, which I think are of more interest here, and that's particularly one in the Southwest and one in the Northeast. And then we have a lot of non-governmental and foundation partners and an international network called the Global Heat Health Information Network. So that's a larger activity than just what I'm speaking to you about here. And the last piece specifically on NIHIS, I'm going to just show you a couple of products and then leave with some opportunities for coordination and input from you. I want to put here was created to provide a common system. So again, many of you are already dealing with heat in some way, shape, or form in your communities and your healthcare facilities. I know we're going to hear from Dr. England in a minute. They're doing a great job in Arizona on this. But what do we actually need to learn from that for improving the information we deliver at longer time scales? How do we actually facilitate planning in a different way? So in the facility I was in Chicago, I saw, children and parents sitting in the waiting room waiting to see their doctors, and there was nothing on the table. I was like, wow, what a great opportunity to communicate about reducing heat risk, just a piece of paper on the table for somebody to pick up when they're bored waiting for the doctor. Something as simple as that could have a huge effect. And educating you all who actually directly deal with patients or involved in those facilities can be a huge boon to actually just making people aware of the risk and then, making sure they know where to find the information so they can manage it. I will put one thing here because we were talking about the title of this had mental health and vulnerable populations. And I do want to stress that there are I don't know that the literature is so great on mental health effects of heat, but I know with extreme and repeated events and stressors of life, environmentally driven from floods and disruption related to hurricanes and tornadoes, there are a lot of mental health effects associated with that that are coming for, and I wanted to just put that out there for conversation. I don't know that that's the main thing we want to focus on in terms of response, but I will leave that to those of you who deal with people on the ground all the time, and know that that is coming up repeatedly as more of an impact of climate and extreme events than we had, than we're really prepared to with information to deal with. Okay, so now we're getting to the tools part. This is just a snapshot of the NIHIS web portal. And a web portal is a web portal. Great, you're probably thinking, right, another resource. But we actually have here all of the heat forecasts that the Weather Service makes. We have here all the federal tools for guidebooks and guidances. We have here links to CDC and EPA and FEMA and OSHA and NIOSH. So all of the federal family is together here presenting their heat information to the public. Now, could we do a better job? Absolutely, I'm sure we could. Would we like to be working with you who are actually dealing with people on the ground more regularly? Yes, that's why I'm here. So, but this is a very good start for putting all the information in one place. And then just a couple of things. So I just want to make sure you know we actually do a heat outlook. This is the Weather Service. They are a part of NOAA. This is our 6 to 10 day heat outlook for coming up to the end of May 4th. And you'll see the margins on the eastern and western parts of the country of higher than likelihood of heat. And this is a 3-month outlook. So you'll see over the summer, we're expecting higher heat impacts in the Southwest, the Gulf Coast, and the Northeast. So I'll skip these here and just go to this one right here and talk about if we actually can use our environmental information, our forecast tools and opportunities to get ahead of the curve, we can move our ability to reduce the impact of whatever the health effect is, heat or an infectious disease. It happens to be an infectious disease curve here. But the opportunity to reduce the impact is that entire yellow area if you get a longer lead time. And we can do that with the environmental information we have. We just can't do it without understanding what you need, working with you to make sure that we're communicating it well and that you have what you need to protect the populations you serve. So the last slide here for stimulating some discussion is, what do you need to prepare and protect your populations? Can you help educate them? Can you help improve planning and budgeting and doing things a little bit differently to manage the different time scales and know that we're going to have more extreme events happening, extreme heat waves coming? What do we do differently, and how can we help you do it? So my last slide here is just some technical resources, and Jose said these will be available to you afterwards. And if you just even Google NIHIS, you'll be able to find it pretty easily. And the last slide here is just to remind us that we can't solve the world's problems of tomorrow the way we were thinking about it in the past. So I'm looking forward to the discussion, and I shall stop and turn it back over to Jose. And thank you very much for the time.
Thank you, Julie. Thank you for this outstanding presentation. And now we are going to hear from Dr. Bob England. Dr. England is the director of the Maricopa County Department of Public Health. 4 million people, it is the 3rd most populous local public health jurisdiction in the U.S. Since he began in his position 11 years ago, his mission has been to look for innovative solutions to rebuild the local public health infrastructure in a resource-poor environment. He's been a public health doc his entire career and has held several positions in state or local public health in Arizona and in Connecticut, including twice being the state epidemiologist for Arizona. Good morning to you, Dr. England.
Good morning. Thank you very much for having me here. I'll tell you, after listening to that description of the problem, I feel even more inadequate than I did coming into this in terms of our response. So let me just briefly tell you where we are. Metro Phoenix, where nearly all of our population, about 60% of this entire state's population, is in that little oval that you see on that map surrounding Phoenix. And news flash, it gets hot in Phoenix in the summertime. Our 100-degree plus highs usually start mid-May. I was really looking forward to telling you that it started last weekend, but we only hit 99 over the weekend. We have nearly a month where our max temperatures exceed 110. And more importantly, we have typically a couple of weeks where our minimum temps, our low for the night, exceeds 90 degrees. So we had no heat surveillance system in place at all, no system for impact of heat up until 2005. In 2005, there were a number of deaths that caught the public's attention even without a formal surveillance system. And you can see from that curve there that happened in mid-July that the difference in temperature wasn't so much the high as it was an increase in the low that was sustained for several days and resulted in individuals who couldn't get in out of the heat, their bodies not being able to cool off at night, and the cumulative effect of that. So we had a lot of media attention to a problem that was not new, certainly, but was newly being paid attention to, of heat-related deaths in the homeless, especially in Phoenix. This prompted the creation of the Heat Relief Network, where a number of partner agencies, cities, the Maricopa Association of Governments, various community-based organizations and churches got together and with a goal of preventing these deaths. We created water collection sites and cooling centers, which for the most part were buildings that were already open to the public. I have to tell you, this was not a new phenomenon as much as it was a new mission for these locations. We also started ramping up public communication, both in terms of signage, media, internet communications, and so forth. Now, we did a survey in 2014 of how well this was working, and went to look at this point, 52 cooling centers. And some of the stuff was working as it was intended. Most were easy to get to, meaning transportation-wise. All of them were distributing water that had been donated, but relatively few had any indication at all on the outside that part of what this place was a cooling center. So people were coming in for various reasons, or to get out of the heat, without necessarily even hearing the word that that's what this was for. We did a survey of people there, and about a fourth of them heard about it through word of mouth. Some just noticed it and walked in, and very few heard about it by the system we had been using to communicate to locate these locations, which was an internet-based mapping tool. And that's not at all surprising. Only about 15% of people who came in were coming in to get out of the heat. Most of them were coming for other purposes. These are government buildings, they're libraries, some of them were churches and so forth. And so people's reason for being there was relatively infrequently to get out of the heat. In looking at who was there for that, was coming there for that and for other services, not surprisingly, you get a lot of people who are unemployed, homeless, and a relatively small fraction of people who actually came in because they didn't have air conditioning. That's of import that I'm going to make, an important point that I'm going to make in a moment here. So if you look at how we did, right after we implemented this thing in 2006, we were patting ourselves on the back pretty seriously. We had a significant decline in number of heat-related deaths, especially in the homeless population. The purple bars there are homeless, deaths among homeless. The red bars are others, and the yellow line shows the percentage of deaths that were in homeless. But you can see right from the beginning, most of the deaths weren't in homeless people. We had developed this system which, through word of mouth among people living on the street, was working to some extent for homeless individuals to be able to get in out of the heat and let their bodies cool off. But we weren't really doing much for others. And last year, you can see everything went up again. So this is not a system that's doing all that well. I would point out that we place a lot of emphasis on outdoor deaths, but we have a significant number of people who die indoors, and that was a puzzle at first. But if you look at where we have high amounts of heat morbidity, large areas of lower socioeconomic status, perhaps not having air conditioning either operational or available at all, and we don't have our cooling centers very well saturating that area for people to be able to get to if you don't have wheels to get there. So in addition to the cooling center evaluation that we did in 2014, we did a community-wide assessment. And those of you who are in the world of preparedness and response, you know the acronym CASPER. And we found that folks readily told us, yeah, a fourth of people said they don't use their air conditioning the way they might like to because the cost is a significant barrier for them. And yet, fewer than half of those folks were aware of even LIHEAP or other utility assistance programs that are available. We're currently doing a homebound assessment for folks, and that's going to be more of interest. That and the community-based assessment is going to be more of interest, probably to the populations that you serve in connection with public housing. So what do we do now? I got to tell you, I feel like our response program is truly inadequate. It just responds to heat warning days. We clearly don't get the word out well. There's widespread community agreement among the partners as to the importance of this, but nobody's stepping up to take the lead. And I have to say, including my organization, which I could talk to you endlessly about our resources here, or lack thereof. But we don't have a clear leader at this point and a clear plan. We are hosting another planning meeting coming up on the broader issue of climate change and heat. And hopefully from that, we're going to take a significant step forward here in being more responsive to this issue, because it is going to be a huge issue for our community, given how hot we are to begin with, as the climate continues to warm and our heat island simply continues to grow. If I had one nightmare in our world of emergency preparedness, it's a significant power outage here in the middle of the summer, and we need to be better prepared for that kind of event. So that's it for me. I'm really looking forward to the third part of this, and hopefully I can learn some lessons from elsewhere that we can try and apply here.
Thank you, Dr. England, for your presentation and showing not only your achievements, but the challenges that you have. So thank you so much for sharing that information with us. Now we're going to hear from La Maestra Community Health Centers. La Maestra Community Health Center is one of the Public House Primary Care Grantees. And we are going to hear from Zara Marcelian. Zara is the CEO of La Maestra Community Health Centers and La Maestra Foundation. La Maestra Community Health Center is a nonprofit, federally qualified health center with more than a dozen locations in inner city areas of San Diego County, including school-based and mobile clinics. Nearly 500 staff guides more than 45,000 patients per year to access healthcare and social services, most of whom are immigrants, refugees, homeless, survivors of violent crime, and low-income individuals with complex health and well-being needs. With Zara, we have Tom, who is the Director of Corporate Compliance and Risk Management for La Maestra Community Health Centers. Tom oversees all ongoing activities related to clinical risk reduction initiatives, including safety and emergency preparedness. Good morning, Zara, and good morning, Tom.
Good morning. Good morning. Thank you so much for this opportunity to present some of our experiences, concerns, programs that we've initiated here in San Diego, specifically for La Maestra and, the community in general, because, the different areas that La Maestra is in, it helps like the families, even if they are not attending La Maestra during emergency situations. We just wanted to give you a quick overview, some pictures of the clinic facility. For 20 years, we had 14 old restored residential buildings that we had to bring up to code and maintain that way, and air conditioning was a huge issue. And then after 20 years, we were able to build this fantastic Gold LEED certified building, 36,440 square feet, very comprehensive healthcare services, specialty as well, including imaging. We had 2 floors of basement underneath, which we were thinking about in emergency situations. You'll hear more of that later. And we still occupy the other 14 buildings for our social determinants of health programs like housing, youth programs, microcredit, economic development programs, art, lots of cool stuff, community garden. So we still have that challenge as well, to keep those going, and what to do in the summer when we lose power. Go ahead. So I'll turn it over to Tom because, I think that La Maestra, well, I know La Maestra has been first in terms of our participation long time ago with the state of California for emergency preparation, and also with the city, and has piloted many different communication, radios and whatnot, and computer system software. But, at the end of the day, if you're without power, which Tom will describe, with our 28 different languages, it's really tough. So we really utilized our cultural liaisons that we have for helping with explaining the services to patients from different countries that perhaps don't understand, where to go for different resources. And then they also, of course, inform our providers on what the beliefs and the values and traditions are of those cultures to be able to, relay the message. So here's Tom. Thank you so much.
Thank you, Zara. Yeah, as Julie and Dr. England pointed out in their great presentations, in Southern California, we are feeling the impacts of climate change, including things like wildfires, heat waves, water issues, and in some communities, air pollution and higher asthma rates. And injuries can range from anything. They can range from headaches to nausea to extreme events such as heat stroke and cardiac arrest. We just saw on the news just recently in Texas, there's a 2-year-old boy died after being left inside a hot car. The police say that the child was left in a hot car for up to 5 hours. And I'm looking here, it says one family member thought the other family member was taking the child out of the vehicle. When they got back in the vehicle and went home, they discovered the child was still in the car. So it's really sad. These are things that we really are dealing with. And, climate predictions say that temperatures are going to continue to rise. So with that, as health centers, we do have to tap into city, county, and regional emergency preparedness planning to share our resources. We have to build partnerships beforehand. It'll help improve response times when an emergency does happen. And then we've just found that building relationships with your county and with the city helps to ease the financial burden of an emergency when it does happen. We have a network of partners to help reach out to our culturally diverse communities. We have partnerships with the County of San Diego Health and Human Services Agency, Public Health Services, the Health Quality Partners of Southern California, San Diego Police and Fire Departments, the Division of Emergency Medical Services, and the California Office of Emergency Services. As a community health center, we have a good relationship with Patrick Klein, who is in charge of the health center operations in Sacramento. They are a great resource of information, helping us build an emergency preparedness plan, a surge plan, and helping us calculate doses of medications that we might need for in order to be self-sufficient during an emergency. On a local level, we collaborate with the Health Quality Partners of San Diego. They're formerly known as the Council of Community Clinics, who sits at the Medical Operations Center as our point of contact to the County of San Diego. And so we're in constant communication with them, who help us follow state guidelines. So we have collaborations with community-based organizations, ethnic media, and community representatives. The roles of the health center. So, in instances when there is a sudden increase of volume of patients due to an emergency, we understand that our role as a health center is to be the community's support system, life support system. And we understand that we may serve as a triage center where patients go for information and they might come for shelter in an emergency. We might provide medical care to relieve hospitals that are overburdened with patients. We have to be prepared to serve the needs of many groups, diverse groups, including unexpected populations. We have to be aware of existing resources available for, during, and after the emergency, and maintain ongoing internal and external communications. Sourcing and storage. One of our goals in terms of storage was to have the ability to respond with medications to the public if there were to be an emergency, a fire, a power outage, a heat wave. But the difficulty had always been in figuring out where to store these medications and how to keep them from being exposed to really high temperatures. So as part of our emergency preparedness plan, we put together a list of medications. We kept it aside as an addendum to our surge plan. And the concern was, as you can see in the first slide, the picture, we have a 3-story building. But even with all that space, all that square footage, storage is still limited. And even if we found storage areas, drugs can't be exposed to temperatures higher than 86 degrees. So as a result, we enlisted with the San Diego County Emergency Services to be a point of distribution, or a POD, or a pod, to have stockpiles of medications or vaccines delivered to us in the event of an emergency. And that would be done in order to help protect San Diego County residents. They deliver up to 1,000 doses within each hour within 48 hours. So instead of storing these medications, there wouldn't be anything to do really on our part. We just have these medications in our back pocket. And the County of San Diego participates in this medical countermeasures program, which is administered by the CDC, the Centers for Disease Control. And currently, there are large amounts of doxycycline and ciprofloxacin available through the Strategic National Stockpile program. So in instances of an emergency, the CDC ships the medication to the San Diego County, and then the county distributes the medications to us as a pod. So this is a great program worth looking into in your county. If you do consider storing your own supplies, we recommend looking into the Direct Relief International. They have a lot of medications and medical supplies to offer. The Public Health Department and Emergency Management Agency. Look to your vendors, build relationships, and find out what their emergency plans are. In terms of storing your equipment and supplies, consider having adequate conditions and accessibility during an emergency. Regular testing of your refrigerators, generators, flashlights, whatever it may be, and then expiring or rotating out those medications if you do decide to store them. Disruption in service. To prepare for heat waves, we want to be proactive in collaborating with our local utility companies. They're our front line. And what we've done is we've registered as an essential user with San Diego Gas and Electric. And that means that we as a health center are on the priority list to have service brought back to us during a blackout. We understand that as a health center, we provide vital services, so it's really important to get on the local utility company's priority list. One thing in terms of disruption of service, which I don't have on here, is during a disruption, whether it's planned or unplanned, we do have a process in place to make sure that we can continue seeing patients and make sure that information is recorded on paper and that it gets entered into the electronic health record. We use a program called ChartGuard. And ChartGuard is a software program that automatically generates printable copies of clinical charts as a backup in the event of an EHR system outage or a power outage. This was purchased and put in place as an option to prevent diminished quality of care and a loss of revenue. I mean, even when a system or network is down, ChartGuard prints out 3 days worth of clinical charts as a backup, and they're always available, and that allows patients to continue being seen, and it avoids downtime. So this allows us to continue seeing patients and to document patient care, something worth looking into. At the community level, we work with the Environmental Health Coalition to develop educational materials for patients. We provide online outreach to communities dealing with high rates of asthma and extreme heat to sort of bridge that connection between climate change and health outcomes. We provide materials with actions to take home to address these risks in the community. And through this partnership with the Environmental Health Coalition, over 11,000 patients have learned these risks through direct outreach and patient educational materials. Educational materials like this heat illness injury prevention brochure, we found that patients often prefer written communication, so we try to make sure that it's expressed in plain language and made as clear as possible. This really means just using simple everyday language, using the same words in writing as you would in talking, using short, complete sentences, keeping documents short, using headings and subheadings like this, keeping the format clear, and just focusing on one issue at a time. As far as community resources, we collaborate with key community resources to coordinate for our underserved populations. We coordinate with public safety and security, the fire department, law enforcement, public works with food safety, animal safety, disease surveillance, federally funded local response initiatives, utilities, energy, water, communications, and public schools. As far as training and exercises, members of our staff do attend a monthly safety and strategic communications meeting, which includes roundtable discussions of best practices. And topics like this include web EOC trainings, disaster training, training with emergency radios, and really defining safety roles and responsibilities. This past year, we participated in X24, which is a really great exercise that combined using social media and collaborating web tools that shared real-time information to help victims of a natural disaster and emergency situations. We also participated in the Golden Guardian exercise. It's a statewide exercise to prepare organizations for different emergency scenarios in surge planning. And then other exercises involved, over 49,000 participants, and it focused on connecting individuals as well as communities. So the roles of our partners, we do look to our partners to provide equipment and supplies. We look to them to provide preparedness information, resources during and after an emergency, assistance with the communication process, both internally and externally, to address the needs of our vulnerable populations, the elderly, the disabled, to treat acute injuries, hospitals and volunteer physicians, and to provide shelter. Wildfires and blackouts, really quickly, we experienced we call them the California blackouts, but they affected California, Arizona, Mexico. And during this power outage, we learned that we're left without air conditioning, without lighting, hot water, even running water. Our cell phones weren't working, so there's a loss of communication. And with that, we learned that we have to be self-sufficient. We seem to lose power when it's needed the most, when it's hot. So these are risks that we're working to minimize. Our clinic, as you saw in the pictures, a 3-story building with 2 underground parking garages. It's large, and it would require a really large generator because of our size. So you'll want to look for backup sources of energy, such as power generators. Electrical contractors can come out to your clinics to give professional evaluations in terms of needs and costs. Cost is always a major hurdle. In during the blackouts in San Diego, it knocked out power to 1.4 million people and knocked out power to the hospitals. Emergency generators failed at 2 of the hospitals here, at Scripps Mercy Hospital in Chula Vista and Sharp Memorial Hospital in Serra Mesa. There were several patients that had to be transported to other hospitals during the blackout. So the first course of action would really be to contact your utility company to be put on a priority list, and then contact your local emergency management agency to see if they can provide a permanent or even a temporary generator. In terms of communication here at La Maestra, our call center, we do have a call center. They can be utilized specifically for emergency outbound calls and incoming calls. The telephone lines can be established where patients can receive up-to-date emergency instructions and guidance in one of many different languages. In terms of text messaging, we use a program called Care Message, and it's a great platform which gives us the ability to send out mass text messages to patients, and it's great because it's so efficient. These were originally meant to send patient appointment reminders and reduce our no-show rates, but we learned that it could be used for communications in the event of a power outage, a heat wave, or an earthquake. And we're even able to create groups based on filters to target specific populations and provide more targeted outreach. So we found that sending surveys and collecting data from any patient population, reviewing those results in real time was really important. So texting is a useful way for us to provide two-way emergency preparedness communication. Two-way communications include things like just basic telephone systems, emergency handheld radios, cell phones, email, social media, paging, two-way radios, text messaging like we talked about, using the intranet to communicate with our staff, and smartphone apps. Like Zara said, we use interpreters and liaisons for face-to-face encounters. We hire bilingual staff and liaisons to discuss health and safety topics, and this helps to create, build trust within our communities. We provide a lot of translated materials in different languages, a lot of printed materials with links to websites that offer translated materials, and we're working on our La Maestra website to be converted to a multi-language website, which is a built-in language switching mechanism that allows our visitors to switch from one language to another. That'll be really helpful. With community engagement, we ask ourselves, how do we provide education to our diverse patients, and how quickly can we disseminate this information? We've just learned that there's no one-size-fits-all approach in terms of a strategy for communicating. We know that in culturally diverse communities that are limited in English, they're just really difficult to reach. So we try to combine our communication methods with community-based organizations to help disseminate health information to our diverse populations. So in terms of emergency preparedness, we're always in the process of updating our emergency plans to include hazards that might affect the clinic the most, like disruption of services and fire and heat and medical emergencies. The components that we're looking at here that we find are really important are collaborating with our partners, action plans for specific types of outreach, continuity of operations, storing equipment and supplies, communicating both internally and externally, having team roles in terms of disaster and emergency preparedness, and having post-response evaluation procedures. Our manual is continually being updated as a guide to identify hazards that have happened or could happen to us as a clinic, and it plans for unique actions for each of those. So really, by understanding our community and developing these relationships, it helps us identify what works and what doesn't. And we can continue to assess these plans and follow national best practices in order to keep the safety of our community a top priority. So with that, we want to say thank you for attending our presentation. Here's a list of some of our emergency preparedness partners. We hope you found some of this useful and you can take a few points. I know there are a lot of topics that were covered today, so if you'd like to contact us at La Maestra, our email address is here below. Other than that, stay safe. We look forward to hearing your thoughts, and I'll turn it back to Dr. Leon.
Thank you, Tom, and thank you, Zara. I just want to point out that I am very honored to work with La Maestra. Throughout the years, we have established a great partnership, and La Maestra is one of the greatest collaborators that we have. It's been an honor, and La Maestra is part of the clinical quality working group, the emergency preparedness working group that we have. So thank you so much again for this presentation. And thank you, Julie, Bob, Zara, and Tom once again for your presentations. We are going to start the Q&A session. If you have any questions, please submit your questions through the question box on your control panel, or use the hand raise icon and your line will be unmuted. All right, we have a couple of questions here. The first question is, will La Maestra's slides will be emailed out or available? I can answer that question. All the materials, the slides, and information about this webinar will be emailed to all the attendees, and the resources will also be available on our website at www.nchph.org. We have another question for La Maestra. Can you please explain again the role of your community liaisons? Liaisons, I'm sorry.
Yeah, no problem. Well, our cultural liaisons, what the role was, and we basically developed this initiative when we started the clinic in 1990, was because we knew that in order to serve the populations, the diverse populations, we should have people on our staff that are from those populations. And that has worked very well, not just with refugees and ethnicities that are different, but also groups of people that have a lot in common. Let's say veterans, or people that are from the substance abuse, let's say recovery community, that have just come out of jail, or some kind of correctional facility for drug-related crimes. Who's best to work with them as a cultural liaison, somebody from their background, from their experience in life, and will know how best to reach them and what message is going to work. So that's kind of the concept of cultural liaisons. What we did was we identified in our communities, among the different refugee groups, people that had experience working in refugee camps or abroad in the healthcare field that wanted to continue that. We then put them through orientation, training. They got certified to be either a medical assistant, referral clerk, patient service rep, lab, many different positions. And then they work to help do that translation, and more than translation, interpret the culture and make sure that we continue to remain sensitive to the diverse needs. I hope this answers the question. Any other question, please just send me an email and I can contact you.
Thank you, Sarah. And I believe this question is for Julie. Julie, in addition to the resources provided on NOAA's website, does NOAA provide training for healthcare facilities on excessive heat and heat waves?
So thank you for asking that. Jose and I have talked about that, and we have not done a targeted training specifically, but if there is actually a desire to do that, we would be happy to do that. And it would be, I would hope, it's very much a two-way street. Happy to show you kind of what we've got, but also, I think one of the points I'd like to reinforce here is that from a public health perspective, those of you who actually are on the front line, like La Maestra and like Dr. England's group, we very much need to hear from you what you need. Our agency, especially the part that produces the products, needs that, what they call requirements. So yes, we do training for other things. We have not done one specifically on heat, but would like to, so we can follow up with you on that if you would like, either directly or through Dr. Leon, and let's make it a two-way street so we can learn from you as well.
Thank you, Julie.
I just wanted to say something real quick. The N95 masks were a super huge need for us when we had the fires, people with asthma, there was ashes blowing all around. And that's what we were told that we needed, but that, our providers needed to change the mask many times a day, and the masks were extremely expensive. So that would be something that I would just start this list off with. Thank you.
Thank you, Zara. Thank you for that. And there is another question, and I believe this is well, I believe that these are two questions, Zara. The first question is, does La Maestra provide services to the homeless population? And the second question is, how do you provide the emergency preparedness information to the homeless population?
I can take the first one. Yes, we do. We have numerous outreach in medical, dental, optometry, social service programs for homeless, as well as transitional housing. So we have services here at La Maestra, and then we go out on our mobile clinic to set specific areas in the city with our partners that can, let's say, take somebody to a recovery center right away, or another facility that will help them with, some other need that they have. So we all approach this collectively. So that's a really cool program. And yes, we do have, materials for the homeless, and Tom will tell. Printed material.
Yeah, printed materials are really big, especially for us in understanding our community. It's not just a homeless population, but a population that speaks other languages. So we have to communicate, like I said before, with our homeless population and diverse populations, and it really depends on the availability of those language services. So we have to keep constant communication with our homeless population, and that helps us identify the different range of languages that are spoken. And then, like we said, face-to-face demonstration, people pounding the pavement, our liaisons, always allows us to address any questions right away, any misunderstandings that they may have in the community. And then we work with our local police department really closely in our community-based organizations to help us disseminate that information.
We found it to be very helpful to have our mental health workers also, because people are very concerned, they're very nervous, anxious, and it just makes their health conditions worse. So that was what we did a lot, was, and our cultural liaisons were fantastic at that, allaying people's fears, providing that information. So that's kind of what our experience was.
Actually, this is Julie, just one comment on that. It's interesting because one of our core partners is the mental health group here in Health and Human Services. They were also quite aware, I guess they're hearing from you guys, that that's a big issue as well. So, I think the mental health consequences, they're hard to quantify in terms of usual dollars and cents that people like to, easy to evaluate, but huge problem. I also, Jose, wanted to mention one product. I heard a lot from both Dr. England and La Maestra about power and power outages. And so first of all, I think we're striving to work with our power communities and our NIHIS pilots, but there's also a product called Empower, and it's on the NIHIS site. I'm sorry, I hate to point you to a site, but it was developed precisely to target, not to target, but to identify populations that are, require medical devices. There's a terminology that you would use that I'm not coming up with right at the moment, but it is developed by our Health and Human Services to map folks where that require electrical power, to largely manage where to turn or at least provide input to the electrical utility companies where to turn the power grid on first, to keep the populations at home rather than in the hospitals. So the hospitals are freer for the real emergency situations, not just people who need power, even though without power it becomes an emergency. So this tool is called Empower, EMPOWER. And those of you who are looking at that intersection of the power grid and your at-risk populations might find that useful.
Thank you, Julie. I will follow up with you after the webinar to see if we can send additional information to the attendees. Thank you so much for that. And we have one more question on Dr. England. I believe this one is for you. Has Maricopa County worked with community health centers or clinics or hospitals to prepare for heat waves?
Thanks for the question. We do work with some of our FQHCs on, actually all of our FQHCs on many different issues here. They are at the table as part of the heat relief network. I can't tell you that we're doing all that much concretely with them at this point. And it's a resource issue, and it's some of the things that were mentioned by La Maestra also apply here. We participate, of course, in exercises that includes the Community Health Center community with the Arizona Alliance for Community Health Centers, our PCA, and with other partners. So the potential for, and we have arranged for participation in our pods as well. So some of those pieces are certainly there, but heat specific, not nearly enough. It's not that the communication lines aren't open, it's just that I don't think we really have a clear plan for what to do.
All right. Thank you, Dr. England. And I don't see more questions in the queue. So to all of the attendees, and thank you so much. I just want to remind you to please complete the post survey. This is our contact information. You can also visit our website at www.nchph.org. You can find information on upcoming webinars, monographs, and other kind of training and technical assistance, publications, newsletters, information on our symposium, information on one-on-one training. You can also join our mailing list and receive information on HRSA updates, Medicare, funding opportunities, senior programs, resources and services, and recorded webinars and upcoming webinars. You can also follow us on social media, Twitter, YouTube, and Facebook. And if you have any questions, please feel free to contact any of our staff members, and we will be more than happy to provide you with the training and technical assistance that you require. Once again, thank you so much, Julie, Dr. England, Tom, and Zara, for your wonderful presentations. Have a good afternoon. Thank you so much.
Thank you very much.
Thank you.
Thank you.
Thank you.